Okay, welcome. Thank you everyone for joining us on the Institute for Health Disparities Grand Rounds presentation. We are very excited to have Dr. Waridibo Allison, our Vice President of Health Policy here at the Health Science Center, present to us today. She attended Imperial College School of Medicine in London, completed internal medicine residency at York Presbyterian, Weill Cornell Medical Center, and Infectious Disease Fellowship at NYU. She holds a Ph.D. in Public Health and Community Medicine from the Kirby Institute, University of New South Wales, Australia. She is elected to fellowship of both the American College of Physicians and the Infectious Disease Society of America. Dr. Allison is passionate about the health and well-being of underserved populations and believes health care access to be a human right. She has been successful in securing several years of continuous federal funding for her work, which includes establishing and directing the National Rural Telementoring Training Center. So welcome, Dr. Allison. We are excited to hear your presentation today.
So thanks for having me here today. I'm going to talk about disparities, data, discrimination, and pandemics, learning from the past to change the future. I have no disclosures to make. I hope that by the end of the hour, together you'll be able to define health disparities versus inequities and describe the importance of history in relation to health inequity. That you'll be able to describe the history and dynamics of pandemics, to describe the interaction of infectious diseases, pandemics, and stigma, to give historical examples of flawed data contributing to health inequities, describe health inequities and stigma in the context of the current COVID-19 pandemic, to give current examples of health data contributing to health inequities, and to frame strategies for moving towards solutions. So health disparities versus health inequities. The two terms are sometimes used interchangeably, but they're not actually the same thing. So a health disparity is differences in health outcomes, access to care, etc. Health inequities are when these differences are the result of systems of oppression and structural factors that do disproportionate harm to certain groups versus other groups. And health inequities lead to health disparities. So let's take a look at the past: pandemics, health inequities, and data. Some years ago, I was invited to speak at the annual conference for SALA. SALA is the Association for the Study of African American Life and History. And I almost said no. A senior faculty member had advised me I still do get a lot of invitations to come and present, and Wari, use your time well and don't go to what is essentially an academic history conference and not my discipline at all. But I thought about it and I started to look into what they'd asked me to talk about, and they'd asked me to talk about health disparities for African American women specifically. And I started to, well, it's an academic history conference, let me look into some history, more than I usually would do, right, for the types of conferences and things that I speak at. And what I found was that history really matters when it comes to health inequity. There are historical forces at play that are intensifying health inequalities in the present, and a historically informed analysis or analyses that reveal and not obscure these forces are really important if the persistent question that has remained to be present to the present is to be answered. And that's, how do we extend the benefits of public health interventions to the most vulnerable populations in what is an increasingly racially and ethnically diverse and economically stratified country? So what's the origin of the word history? The term history comes from the Greek word historia, that translates into an account of one's inquiry, and shares that etymology with the English word story. And I shared this quote from Chimamanda Adichie, who's a Nigerian writer and author. Often when I speak, and if you're a reader, I encourage you to read her books. Half of a Yellow Sun, Americana, they're really great, but she gave a TED talk, which is pretty old now, several years old. And what she says there is the consequence of the single story is this: it robs people of dignity. It makes our recognition of our equal humanity difficult. It emphasizes how we are different rather than how we are similar. Stories matter. Many stories matter. Stories have been used to dispossess and to malign, but stories can also be used to empower and to humanize. Stories can break the dignity of a people, but stories can also repair that broken dignity. And she's talking about perspective in many ways. The saying, there's more than one side to a story. There's several sides to every story, but she's also talking about the power in who tells the story. And stories have a lot of power, but who gets to exercise that power? The Op-Ed Project, an organization who has a mission, they have a mission to change who writes history. And they say whoever tells the story writes history, and who doesn't get to tell the story often. So we need to hear from more women. We need to hear from more gender minorities. We need to hear from more racial and ethnic minorities. We need to hear from more youth. Now, going back in history to look at pandemics and epidemics, they've been around for a long time. They're not a new thing. Looking back at, the 14th century, the Black Death caused by a bacteria, Yersinia pestis, killed about approximately 50 million people. The Spanish influenza pandemic of 1918, again, another 50 million people. The HIV/AIDS pandemic, epidemic, which is still ongoing, 32 million people. When you think about the swine flu in 2009, a lot less, 284,000. And the current COVID-19 pandemic, which is still ongoing, as of last week, about 6.6 million deaths. Now, when you look at pandemics, they're occurring a lot more frequently as the world population has increased. You can just see there on going upwards, like this sharp increase in the number of pandemics. And so it's not a question of if a pandemic will happen again, it's just a question of when the next one is going to happen. And what are the dynamics of pandemics? Really, humans are the ultimate cause. That pandemics are an alarm that we are mismanaging where we exist within a very complex ecosystem. And that alarm has been sounding for a really long time, and we don't seem quite have woken up yet. About 12,000 years ago, humans started to abandon nomadic hunting, gathering, live in more stable locations, cultivate crops, domesticate animals, and for the first time, humans and animals lived in close proximity. And zoonotic diseases that can be transmitted from animals to humans appeared. And measles, smallpox, tuberculosis, other pandemic agents evolved from animal pathogens and switched to human hosts to become human infectious agents. Now, over millennia, the dynamics have changed such that there currently is a spillover of microbes directly from wildlife to people. A lot of factors are involved in that, a lot of them in environmental, deforestation, agricultural intensification, urbanization, ecosystem disruption. This has led to emerging infectious diseases, hemorrhagic fevers, Nipah virus, hantavirus infections. Live animal markets, particularly, but not exclusively in China, have been implicated since 1919 in influenza epidemics and pandemics and coronavirus pandemic. It may seem like stating the obvious, but where people travel, microbes travel too. There's no wall high enough or long enough to stop microbes from traveling. And when you look back to the bubonic plague or Black Death caused by Yersinia pestis, it followed the trade routes from what is now Mongolia and China across Asia into Europe. Between 1793 and 1798, major port cities in the US, such as Boston and New York, were repeatedly struck by repetitive deadly epidemics of what was called the American plague, but was in fact another virus, yellow fever. It's a mosquito spread virus. The mosquitoes traveled on Caribbean trade ships. This map shows major routes of the medieval Silk Road, a lot of overland travel, as you can see. Travel by sea, but travel by sea was short distances back then. Advance of several centuries, and the transatlantic slave trade routes are across border, but a lot further distances. The ships are better, they're good enough to trade, carry human cargo. And this is a route map of just one airline. I just picked Emirates, actually an old one from 2018. This is just a route map of one airline. And if you imagine how many airlines there are, just imagine how many routes there are across the world. An often forgotten aspect of travel-related transmissions of infectious disease is the consequences of exploration. An example is what one historian has described as the Columbian Exchange. After the first voyage of Columbus to the Americas in 1492, syphilis was brought back to Europe. Europeans coming to the Americas brought smallpox, measles, and other known diseases to the native population, and that caused devastating rates of mortality. It continued exploration to the Pacific Islands, as far as Australia, causing the death of indigenous people on such a massive scale that it has never been adequately measured. I lived in Australia for a decade. In Australia, the Kulin people, indigenous people in Victoria, around Port Phillip and Western Port Bays, there were 30 to 70,000 of them in 1836. By 1863, there were just 250 of them left. There are similar stories of devastating loss of life in large volumes of indigenous Americans by an introduction of new infectious pathogens caused a lot of that. The grip of any pandemic causing pathogen is made all the more firm by a population whose immune system has never seen it before. So 1918 in JAMA, the final edition of 1918, said this: the 1918 has gone, end of World War I. So a year momentous as the termination of the most cruel war in the annals of the human race. A year which marks the end, at least for a time, of man's destruction of man. Unfortunately, a year in which developed a most fatal infectious disease, causing the death of hundreds of thousands of human beings. And that was the Spanish influenza. But was it Spanish? The most likely origin was actually Haskell County in Kansas, which was the rail end point of a cattle drive from Texas. And there, Dr. Minor was described as an unusual rural doctor with a taste for the classics. He saw patients with violent headaches, body aches, high fevers, non-productive cough, and the illness killed many of them. He was a physician scientist. He had a lab in his practice, and he examined blood, he examined urine and sputum, tried to find a cause. He couldn't find a cause. He searched the literature, he spoke to his colleagues. He reported his experience to the US Public Service, who offered no assistance, and then it just all seemed to disappear. But it reappeared 300 miles away in a large military camp where recruits lived in cramped conditions, huddled together for what that winter of 1918 was particularly cold. By March, the same clinical picture seen by Dr. Minor emerged in this and other camps. The troops took it with them to the battlefields of France and Belgium and into Europe, and the virus returned to the United States and spread globally, and was called the Spanish flu because war censorship failed to report its true origins. More accurately, it's Kansas flu or even Texas flu. By the time the virus claimed its last victim in December 1920, at least 50 million lives had been lost worldwide. Déjà vu, French phrase that has found its way into the English language, translated means already seen. And when you look at pandemics, it's really interesting when you look at the history to see what we've already seen. So the 1918 to 20 influenza pandemic crept up silently on an unprepared world. That sounds a little bit like March 2020. There was hesitancy and resistance in the face of a growing public health crisis. That sounds familiar. There were weak public health systems. That also sounds familiar. There were political leaders singly focused on a mission to engage in war with Germany, distracting from a war with a virus on home soil. And we all know how politicalized the COVID-19 pandemic was in March 2020 and still is. When you look at health inequities and infectious disease, it's correctly been stated that poverty contributes to conditions that cause infectious disease and also prevent access to healthcare. One paper describes infectious disease as a proxy for poverty and disadvantage, with subsequent risk factors affecting populations with low visibility and little political voice, imposing a heavy health and economic burden and having greater impact where health systems are weak. Stigma, infectious disease, and pandemics are also inextricably linked. What is stigma? A definition of stigma is a mark of disgrace associated with a particular circumstance, quality, or person. Stigmatization of a race, country, or community as a source or carrier of disease has occurred through history, serving often as a pretext for violence and discrimination. Going back again to the bubonic plague or Black Death in the 15th century, there have been different iterations of pandemics of that same infectious disease, but European Jews were accused of causing the plague by poisoning wells. Thousands of them were murdered and entire communities wiped out. Let's look at leprosy, also known as Hansen's disease. Leprosy is caused by a type of bacteria, mycobacterium. Leprosy, stigmatization is described in detail in the Bible far back then, with a priest initially making the decision on whether someone with leprosy was clean or unclean. Modern day India, even after cure with multi-drug therapy and if diagnosed early enough, leprosy is curable, people are shunned at the village level. And one author describes it, an author that works in ethics says the physical and social stigmata of IHD Hansen's disease are too interconnected to be adequately disentangled. As such, leprosy is best approached as an illness of discrimination, inclusive of its physical condition. HIV, I do a lot of my work has been in HIV. It was just in January of 2010 that a new federal rule went into effect that lifted a 22-year restriction on immigration and travel to the United States for non-US citizens living with HIV/AIDS. Words and semantics matter. The names of known influenza pandemics since the late 1880s, Russian flu, Spanish flu, which was probably Texas or Kansas flu, Asian flu, Hong Kong flu. Naming a disease by country of origin emphasizes its other aspect. It makes repressive policies aimed at the disease, but actually at otherness more palatable. The cholera pandemic of 1892, the toll in Europe was so high that the US government decided to quarantine immigrants on arrival. An executive order, you've heard of those, executive order from President Harrison labeled immigrants a direct menace to public health, singling out specifically Russian Jews. One New York physician said the disease entered our court on account of defective quarantine and it has been carried to us mainly by filthy immigrants. Physicians are human too. They're not, there's nothing special about physicians. They also are subject to fear of the overall reason. And this often happens during infectious disease outbreaks, epidemics, and pandemics with high death rates. So let's talk about data. The US Census. Every year, the federal government distributes approximately $600 billion to state and local governments for a variety of things, for education, for Medicaid and other health programs, for highways, for your housing, for law enforcement, and much, much more. The federal government uses formulae with terms for each area's level, income, or poverty rate, racial and family composition, and more. Census is also used for population health data, including calculation of birth, death, fertility rates, all of which require an accurate denominator to be accurate. And so the decennial census, which has occurred every 10 years since 790, provides the baseline data for these formulae, and the census data is important because it also defines how resources are going to be allocated. So let's go back to the 1840 census. The 1840 census newly introduced questions about term back then, completely stigmatizing language that we wouldn't use now, insane and idiots. The census data showed that the prevalence of insanity, again, we don't use the term colored now, but Black population increased the further north you went. So, for example, in the north, 1 in 162 Black people were insane, but in the south, it was 1 in 558. For whites, the insanity rate was 1 in 970 nationally, with very little regional variation. And so what was the conclusion of that? That, I kid you not, that freedom drove Black Americans mad. And so slavery opponents were like, there must be a serious error in the data. And a statistician, Edward Jarvis, who is a co-founder of the American Statistical Association, reviewed the actual paper census returns. And he noted, because this was still in the time of segregation, he noticed that especially in the northern states, the insane Blacks were tallied in local places where no Black people lived. And so what he found was that in paper, poorly laid out typeset of an 80-column table, it was easy to mistakenly enter the wrong data for elderly white idiots into the column for colored idiots. And there was national controversy over this and a congressional investigation, but despite ample evidence of the error, the US Census never declared these data to be erroneous. Let's look at Indigenous Americans and census data. The very first census in 1790 excluded Indians not taxed. The Removal Act of 1830 allowed the US government to force the exchange of Indian lands in any state or territory, increased interest in the number of Indigenous Americans taxed or not taxed. And so by 1880, the census enumerators, the people who collected census data, were instructed to measure, with no instructions on how to do this, to measure the degree to which an Indian had adapted to a European way of life, and to distinguish between full-blooded tribal members and individuals of mixed racial or tribal origin, just by looking. In 1950, the same enumerators were to include anyone who was 1/4 or more blood quantum, just by looking. Many Indigenous Americans did not participate. They were fearful that these questions were a way of exerting more federal control, and their fears weren't entirely unfounded. The 1887 General Allotment Dawes Act granted citizenship to Indigenous Americans who agreed to sell their land previously held in trust and reservations, provided that they had a certain degree of Indian blood. It wasn't until 1960 that the census shifted to self-identity, and self-identity is critical, right, when you're collecting race and ethnicity data. It's important. Misclassification of Indigenous Americans as white by funeral homes has been shown to occur over 40% of the time. It wasn't until 2000 that the census allowed selection of one or more racial ethnic categories. The result? Grossly, for centuries, for decades, grossly inaccurate counts for birth, deaths, total population, leading to severely biased rates and consequences for healthcare and other resource allocation for certain population groups, health inequity. So let's come to the present. In 2020, the Lancet Public Health said this, talking about the COVID-19 pandemic. Beyond these numbers are people, families, communities, societies that have been affected in unprecedented ways. The coronavirus pandemic puts societies to the test. It is a test of political leadership, of national health systems, of social care services, of solidarity, of the social contract, a test of our very own fabric. In the face of this enormous challenge, we risk deepening already stark health and social inequality. Now, this slide, I gave this talk in 2020, a talk in 2020, and I used this specific slide. This is Black and Indigenous Americans showing the highest death rate in those population groups from COVID-19. Now, APM Research Lab frequently publishes the data, and it changed, the levels change, but still Black people have the highest mortality from COVID-19. And back then in mid 2020, although the CDC reported cumulative COVID-19 data reported by state health departments, 78% of those data were missing race, ethnicity, disaggregation as of April 2020. It's improved since then. Now this slide, this study was published in 2014, and it shows measures of exposure to influenza. And I want you, as I talk through it, to think about all the things that we've heard about COVID-19 and how similar it is, deja vu. So structural measures of exposure to influenza: working, living in a metro area, living in an apartment building, multi-generational large households, work-related measures of inability to physically distance, difficulty staying home from work for 10 days, not able to work at home. You won't get paid if you stay home from work. You don't have sick leave at your job. You could lose your job or business if you don't go to work. Your job actually can only be done in the workplace. You can't work from home from it. Other measures of your inability to social distance: you can't find daycare for your kids. You don't have a car, so you can't avoid public transportation. And then look at these, the measures of susceptibility, the chronic conditions that make you more likely to get influenza: heart disease, high blood pressure, cancer, diabetes, asthma, lung disease, immunosuppression. Sound familiar? A lot of those are the ones that make you susceptible to COVID-19. Measures of access to care: you don't have a healthcare provider, you have no health insurance. Lack of insurance or money makes it difficult to get the flu shot. And then measures of discrimination: have you ever experienced discrimination or any hassle when you're seeking healthcare? So all these things that we saw with COVID-19, none of it was new. And so you have these confounders of the ecosystem of social determinants of health relevant to pandemics: limited job and social mobility, frontline jobs with lack of PPE, it's public transportation workers, it's those that work in the grocery, in a grocery store, that work in warehouses and factories, the cleaners and the sanitation workers, crowded apartment living or multifamily housing, making social distancing or physical distancing, it's better to say, difficult, multi-generational homes where all age groups live in close proximity, living in food deserts and in health deserts. Their areas of Fort Worth go just east of the of I-35 West, where JPS is. No pharmacies, no clinics. Underinsured and using self-rationing of healthcare as a strategy. That's a typo there. Reliance on public transport, health beliefs and behavioral choices that manifest differently across different cultural norms. And then let's talk about the consequences for schools. Homeschooling, having an internet, having a device, having a quiet place to work, access to school meals, not having these things disproportionately affects low income and minority kids. Economic recession that can follow pandemics, and we're already starting to see following this one, affects child poverty and well-being. So we already have data that shows that summer holidays in US schools are estimated to contribute to loss in academic achievement equivalent to 1 month for children with low socioeconomic status. So imagine what 2 years of schooling at home did. Mathematical and literacy skills gap between low and high socioeconomic background kids often widens during school holidays. Imagine how much it widened over 2 years of going to school from home. So let's talk about stigma and COVID-19 and even monkeypox virus. The level of stigma associated with COVID-19 is based on 3 main factors. It's a disease that is actually still new, despite the fact that we feel like it's been around forever. And there's still many unknowns. There's so much that we don't know about long COVID. We are often afraid of the unknown. I've talked about the fear factor. And it's easy to associate that fear with others, things, people that are different from us. And that stigma can drive people to hide their illness to avoid discrimination. It can prevent people from seeking healthcare immediately. It can discourage them from adopting healthy behaviors, and it undermines the social cohesion, which is really important when you're trying to combat disease outbreaks. We still have problems with flawed data related to race and health. So this paper describes analysis of a widely used commercial prediction algorithm applied to approximately 200 million people in the US each year, used by a number of different hospitals across the country, a number of different health systems. And the point of the prediction algorithm is to identify patients at high risk for allocation of additional resources, which these hospitals and health systems want to provide. Now, the authors compared Black and white patients and found that at a given risk score, Black patients were considerably sicker compared to whites. The bias arises because the algorithm predicts healthcare cost rather than illness, but unequal access to healthcare means that we spend less money caring for Black patients compared to white. And so, despite healthcare costs appearing to be an effective proxy for health, it actually is not. And that results in a large bias based on race. And what the authors did was fix this disparity in the algorithm, and they found that that would result in the percentage of Black patients receiving extra help increasing from 17.7% to 46.5%, more than double. It's a warning about the complexities of race and ethnicity data we collect, how it can inadvertently be used incorrectly, and the consequences of that misuse. Unlike the 1840 US Census Insanity era, the manufacturer listened, replicated the results across the whole data set, and worked with the authors to correct the problem. So fever. So think about every time you go to the doctor, what happens? They take your temperature, they weigh you, they stick something on your finger. This paper was just published in September, and it was done at Johns Hopkins, within the Johns Hopkins health system, and they found racial differences in the detection of fever using temporal versus oral temperature measurements. So the temporal, you know, they put something across your forehead, right, to take your temperature, run that thing across your forehead. The author of this paper posted some graphics on Twitter that weren't actually in the paper, but they were really clear. So these are Twitter graphics that I'm putting here, not from the paper. Forehead thermometers miss fevers in Black patients. 23 out of 100 fevers in Black patients would be missed. And that's because of the sensor is light-based. So if there's a lot more melanin in the skin, it's inaccurate. And this slide shows the odds of fever with temporal thermometers. The oral is the reference. White patients in red, Black patients in blue, and they use different cutoffs. And you won't find this in the paper. This was, like I say, is a Twitter graphic that the first author posted, and you can see whatever the cutoff, there were still these inaccuracies with temporal measurements of fever. Why does that matter? Well, temperatures are indicators for so many things. In a hospital setting, it's when the nurse notifies the physician. It's a clinical indicator for a number of really serious life-threatening conditions, including sepsis and bacteremia. And even at home, those of you who have kids, how many times does the pediatrician say, if the fevers continue, bring your kiddo back to see them? And so, and they're temporal thermometers for home as well. So it's a source of health inequity. Now, again, recently published, a pulse oximeter. So what's a pulse oximeter? You put it on your finger. Sometimes it's a sleeve. Sometimes it's just a little dot if you're an inpatient. And it measures the oxygen saturation in your blood. It's important, obviously important. 95% or higher is normal. Anything lower than that, you'll often be given supplemental oxygen in an inpatient setting. It matters for measuring so many things for people with chronic, chronic illnesses like COPD. It matters for COVID, of course it does. And this paper showed racial and ethnic discrepancy in pulse oximetry, again, a light-based mechanism that is a problem when the palm of your hand or the back of your hand is darker. They showed a discrepancy in detecting hypoxemia. The Institute for Healthcare Policy and Innovation at the University of Michigan published a health policy brief, and they looked at additional data sources for patients within their health system. So they looked at 3 groups: critically ill adults in the intensive care unit, children admitted to hospital, adults hospitalized at US Veterans Health Administration hospitals. 11.7% of those in the ICU, critically ill Black patients, had low blood oxygen levels despite a normal pulse ox. Children admitted to hospital, nearly a quarter of them, Black pediatric patients, had low blood oxygen levels despite a normal pulse ox reading. And then when you looked at Black veterans, 19.6% of them had low blood oxygen levels despite a normal pulse oximeter reading. And so in this policy brief, they talk about what are the policy discussion implications for that, changes in FDA warnings and action, and a panel actually met for this. The second panel was convened just last week to consider the problem and hear expert testimony. And what the reason for the meeting convened last week was to look at all the data, because a lot of anesthesiologists and other specialists had concerns about how accurate the data was and whether it was flawed. And what they concluded last week was that there is a problem. So pulse oximeter manufacturers should perhaps have warnings. There should certainly be additional data collection across a large number of different ethnic groups. And then consumer choice pressure: should hospitals and health systems only purchase oximeters which perform equally well across race? And then physician and nursing organizations and training programs. Healthcare workers need to be aware that your pulse oximeter may be giving you an inaccurate reading in a person of color. And what is kind of shocking, again, deja vu, is that this wasn't new. These papers were published in 2022, right? Some of the brief, I think, was published in 2021. But they're studies dating back to 1990, 2005, and 2007 that indicated there may be an issue. But it's taken a pandemic and a new study in that context to bring it to national attention and to the FDA. And so Houston, we've had a problem, Polar 13. It's not Houston, we have a problem, it's Houston, we've had a problem. Despite the modern advantages of antibiotics, sanitation, therapeutic drugs, and vaccines, the first steps in pandemic control are prevention and education. It's not a question, as I said, of if, but when the next pandemic will occur. And confronting pandemics and the consequences of data errors and deficiencies, and then forgetting the lessons learned or just ignoring them, has become a recurring theme for humanity. Now, when you look at pandemic preparedness plans in relation to health and equities, one analysis of 37 pandemic preparedness plans from low, middle, and high income countries, none of the plans systemically identified socially and economically disadvantaged groups. 10 high income countries mentioned some disadvantaged groups, including racial ethnic minorities, but only one plan explicitly described how to engage disadvantaged populations. None of the plans discussed access to medical or public health interventions. None of them addressed the impact of public health transmission prevention recommendations, such as school closing and social distancing on disadvantaged populations. Plans treat pandemics as equal opportunity events, failing to recognize that they are differential events, they're differential impacts on different population groups. And when a population is defined as vulnerable, you have to remember that there is heterogeneity even within that population. A Black population in Atlanta is not the same as a Black population that lives in the Bronx in New York. They're not all the same. And so this is, again, published in 2014, so it's been around pre-COVID. It's a mechanistic framework for countries to test proximal, which are behavioral and biological, and distal, which are social and policy risk factors that could lead to unequal level of disease and death in an epidemic or a pandemic. So when we think about moving towards solutions, pandemic preparedness and response and human resources needs to be at the local, state, and federal level. Obviously, disciplines, medicine, virology, infectious disease, public health, it needs to be clinical, it needs to be research, it needs to be administrative, but we also need to learn from what anthropologists have to say, what social scientists have to say, and actually what public health historians have to say. Significant changes in pandemic preparedness plans need to occur. It's really important to identify groups who may be affected, not just by the pandemic itself, but by the public health response to it. We have to rethink surveillance systems to include socio-demographic data from the start of the pandemic. We should consider mandating collection and reporting of cases and outcomes to be stratified by race, ethnicity, sex, gender, socioeconomic status, and community health status in all states. And we have to pay close attention to not just what data are collected, but how those data are used. Self-identity has to be the gold standard for any collection of race, ethnicity data. And we have to be constantly vigilant about data correlations and causality and directionality conclusions made based on race and ethnicity. Check for confounders again and again. Is the cause their race or ethnicity, or is the cause the conditions that people of a certain race ethnicity are disproportionately exposed to? Simulation methods and modeling can help to assess the impact of alternative health policies on reducing disease. Integrating, as I said, social science disciplines and qualitative data collection is also important. We have to anticipate shortfalls in the availability of adequate healthcare access for certain vulnerable groups. Anticipate it. It happens with every pandemic. Multilingual services, culturally appropriate services. We have to recognize that medical devices that we have trusted for decades may actually be sources of health inequity. I want to talk briefly about health advocacy. And so advocacy is action. Infectious disease, as I've said, disproportionately affects marginalized and vulnerable populations. There's a role to be played in joining the voices of patients and patient advocates to make a difference, and in speaking up sometimes, not always, but for those who can't speak for themselves. The editor-in-chief of the Lancet said this: doctors cannot assume that they have either the trust of the public or the support of governments unless they are willing to take part in the public debate about what kind of society they want for the sick and impoverished. And he also said more doctors, irrespective of their specialty, responsibility, or seniority, need to enter the public arena dispute. And I cross out doctors because I think it's relevant to anybody that works in health and not just doctors. Advocacy is taking action. Because my discipline's infectious disease, and I've talked about how infectious disease often correlates to health inequity, the Infectious Disease Society of America has a pretty strong policy in advocacy, but other organizations do too. Paul Farmer passed away unexpectedly earlier this year, and he was such a giant, and he said a lot of great things, but one of my favorite sayings from him is, for me, an area of moral clarity is you're in front of someone who's suffering and you have the tools at your disposal to alleviate that suffering or even eradicate it, and you act. And that action for me can be in the moment, right? There's a patient in front of me, I can do something to alleviate their suffering, but sometimes it's not in the moment, it's over time. Is there a program that I lead? Is there something that I can do that can make a difference? is that what I've seen led me to think about, oh, perhaps I need to apply for a grant, and keep looking out for that grant so I can do something about this thing that I've seen. And it can be years later before that grant happens. And so sometimes action is in the moment. It's an individual, it's an action right then, but sometimes it's just you're continuously acting like over a period of time. So when research, policy, and advocacy meet, what happens? On the Eleanor Crook Foundation, they do a lot of work around malnutrition globally. And I don't know who said this, but this is on their website. Research without consideration of policy or systems change will always fail to achieve the fullest potential impact. Advocacy without evidence is destined to fail from the start. But when these pillars are brought together, the result can be powerful. Where research, policy, and advocacy meet, well, they meet at boundary organizations. And the Health Science Center is a boundary organization that sits at the intersection of knowledge and policy spheres. And these organizations are more important than ever and should be fully integrated into policy making structures. Along with producing new knowledge themselves, these boundary organizations are lighthouses to policymakers for knowledge. And to solve challenges, these boundary organizations must bridge the gap between scientific disciplines and policy fields. A few years ago, I attended a leadership conference, and one of the speakers talked about the Japanese word crisis, which is translated to kiki. It has two characters. The first character means dangerous, and the second character means opportunity, because those two things exist side by side in a crisis. And so we have opportunities. We've all experienced the lived experience of danger, right, with the COVID-19 pandemic, but there's opportunity in relation to health inequity and the public health crisis caused by the COVID-19 pandemic. We have an opportunity to learn from history and understand the structural and systemic issues that contribute to health inequities and vulnerability during pandemics, to bring about lasting change and move towards addressing those inequities with tangible action that is policy driven and changes the structure of health systems and the organizations within those systems. We have an opportunity to be ready when the next pandemic occurs and not to be surprised yet again by the differential effect on vulnerable population groups. And we have an opportunity to be vehicles of change at an individual level when it comes to health equity. And being a vehicle for changes at an individual level, for me, I sometimes feel that it's like a drop in the ocean. It's like, is it making any difference, for goodness sake? It's like this thing that I'm doing or my team's doing, what difference does it make? And it gets exhausting sometimes. And one of many things I do that to combat that feeling of nothing's making any difference is to think a little bit about my personal history. And I'm going to end with some pictures. So this is my great grandparents who were enslaved in Brazil, actually. And when emancipation from slavery happened in Brazil in 1888, and it was one of the last places to do that, they found their way back home to Nigeria. There were 4.7 million people that were enslaved in Brazil, Africans that were enslaved in Brazil over a few centuries. About 3,000 to 8,000 of them found their way back home to Ghana, Togo, Nigeria after emancipation. Two of those were my great-great-great-grandparents. I think my life would have been really different if they hadn't. Within a generation, this is my great-great-grandfather. He was a lawyer. He was also a journalist, did a lot of writing, eventually became a Chief Justice of Nigeria. That's within one generation of slavery. This is my grandfather. He was a physician. He died before I was born. So I never really knew him, but I did know his sister, my great aunt, really well. And she passed away in 2016. She was 95. And she initially studied medicine, but then switched and went to study social science. And then she worked as a welfare officer in the Nigerian judiciary system and eventually became a lawyer in 1953 at a time when women were not doing that type of thing. This is me and my sister. There are four of us. I have two brothers as well, but I show this picture because at a time where culturally still, it was don't waste your time educating girls. My dad never differentiated with, my parents never differentiated between my brothers and my sister and I. We had exactly the same opportunities my brothers had, and he was always, you want to be, what do you want to be? Whatever, you can be whatever you want to be. You're smart enough and you can do it, and it kind of doesn't matter that you're a girl. And then this is a collage of my son, who's just turned 3, and his cousins this summer, and they give me a lot of hope. I have a lot of hope for them. I have a lot of hope for their generation. And what Desmond Tutu said is that hope is being able to see that there is light despite all the darkness. And so much can change in just one generation. And I end with just a few lines from one of my favorite poems: for there is always light, if only we're brave enough to see it, if only we're brave enough to be it. So thanks for your attention.
Well, thank you very much, Dr. Allison. That was a wonderful presentation. We do have some time for questions, if there are any questions from the audience.
So Dr. Allison, I have a question. First of all, brilliant presentation and very thorough research. So hats off to you, ma'am.
Thank you.
Just as you talked through the presentation, you said there's a lot of movement, right? And the mobility is only increasing internationally, and it will continue to. It's like initially we probably traveled once in a lifetime, and now every week we are going international. So with this comes all these other factors. At the pace with which we are going, the mobility is going. Do you think healthcare can keep up with that pace? If so, how do you suppose? I'm just looking for not a solution, but in a hypothetical situation. I mean, how will that work?
It's challenging because healthcare is so different in different countries, and a lot of that mobility is sometimes moving between those countries. And I practiced medicine in the UK, I practiced it in Australia, I practiced it here, I've done work in resource limited settings like Papua New Guinea, and it's just the access to care is just so different, and the resources are just so different. I think we have to try and keep pace. I think it's a challenge. I think the inequities exist within a country, but then I haven't even talked about the inequities that exist from one country to another. You know, we could talk about the COVID vaccine and what happened there with access. You know, we can talk about PrEP, right, which pre-exposure prophylaxis for HIV. When you look at the parts of the world where most new infections of HIV happen, that's not where most PrEP is, which is one of our most valuable tools for prevention. So I think it's a challenge. I think it's where global health becomes important, and where we, institutions like ours and others, think in a global health way and think about what we have here and what the knowledge that we have here, how that can translate to other countries. I think there has to be that translation of knowledge and capacity building, right? Capacity building within those low income and middle income countries. So I'm sorry, that's not a very good answer, but a good question. I think it's going to be a challenge to keep up, but we have to try.
Absolutely. I have one more question, if I may. Real quickly. So when there is a crisis, right? And what do we say in healthcare? Stop the bleeding first. So people are not thinking race, ethnicity, data, algorithm. Those all come excuse me, later. I understand and greatly appreciate being more proactive, but then take COVID-19. When that happened, it was all hands on deck, rescue, take care of people, make sure they're alive, right? So when we are in that mode, in a situation like that, you know, how do you bridge that kind of a gap where you're collecting?
Great question again. So that situation should never have happened, because we already knew that it could from previous pandemics. And what we didn't do was invest into the public health systems so that all the people dying in hallways should never have happened. And I think that's the lesson, right? That we learn from COVID-19 and go, okay, we need to put funds and resources into public health systems. We shouldn't be caught on a back foot the next time the next pandemic happens. I think that was a lot of the problem with COVID-19, that we hadn't learned from previous experiences.
Dr. Jones?
Yeah, just a quick question. Very nice talk. I'm also curious of the from an academic perspective, we can put this in context of just lessons learned. But from a civic political perspective, they may say we knew all the time, based on the history of social injustices. You know, look at incarceration, for example, where many of the people who are incarcerated don't get free access to health care. They happen to be those from minoritized populations. So when it's very interesting for us as academics to say we'll learn the lesson, we should have known this was coming. But if we clarify strictly what we mean, is certain individuals already knew, based on historical context and the social injustices that are pervasive, that we knew that this was going to happen anyway.
Right. I mean, because when you look at COVID-19, everybody that works in these areas, nobody was surprised. Everybody was like, oh, why is everyone acting surprised? Because we know this. We're not surprised by all this stuff that we're seeing, right? Were you surprised, JK? You were just like, yeah, of course. We know that this happens. I think, speaking to what you talk about, the silos between academia and policymakers and politicians and civic leadership, they don't speak the same language. And I think that's one of the things we have to try to do better as academics, is to speak to those groups and present our research and what we do in a language that they understand, or a language that they can absorb quickly. And it's not academic medical journals, it's not the conferences that we go to and we mingle with our folks, right? The people that do the work we do, and it's nice, it's great. I like going to conferences, but it's not right. We have to start communicating our research to different people, and it takes communicating in a different way.
And also to manufacturers, right? Because sorry.
Go ahead. I was just going to ask, you mentioned about the pulse oximeters and the different thermometers and things like that. We talked a little bit about that in our rural medicine program too, but we were never given a resource on where we could buy products that are culturally or I guess racially aware. Is there a resource guide or like a collection of where we can buy this?
So the FDA, if you Google it, you'll actually see some manufacturers are starting to say our product doesn't do this, doesn't do that. So I think there is some consumer power there. So if you just Google, because I Googled as I was doing this talk to see what happened last week with the FDA stuff. So you'll see some manufacturers are starting to do that. You have to remember that it's only the commercial ones that have FDA approval. The ones that we buy in Target, right, don't. So it's really like the commercial ones that would say that. There's a conversation happening about whether the ones that we buy in Target and wherever that everyone's been buying right through COVID need to have the same regulatory stuff put over them.
Well, and because even my sister's a nurse, and obviously I'm here in medical school, a lot of us students, we get our supplies from like Amazon or Target or stuff like that, because we're sourcing our own supplies. So that's a huge issue for us, because we don't want to go into the field. And even when I was shadowing, a lot of physicians bought their own equipment because their hospitals weren't providing enough.
Wow.
So it becomes a big issue in the healthcare system, because even the consumer products
Are being used, right? Yeah, by the students. Yeah.
We have time for about 2 more questions. So
Just
Leslie and then JK.
I also would love to see more of that. I just wanted to say how much I appreciate this. And we work with school asthma programs, and of course, pulse ox there are used to determine, decision-making criteria. And, we have 350 campuses here, but we're also working on this as a policy issue on the state. So clearly this needs to be at the center as well as things. I'll just look for Spenny. Thank you so much. I know look for those resources.
Can I ask a question?
Yes, final
Because you
comments
already said
from-
last question.
No, I was went to you next, so.
So first of all, thank you very much because you touched upon things that this whole team is working on. You touched upon AI/ML, you touched upon COVID and all of the things that we're doing the community engagement for my SEAL team. You touched upon health disparity. I think this was the most interesting talk for all of them. I do have one question for you, maybe two questions. One is with the COVID pandemic, did we do something right with the COVID pandemic compared to the Spanish flu and all the other things? I mean, I was struck by the fact that it was exactly the same situation between Spanish flu and COVID, right? But did we do something right so that there's only 6 million people who died rather than 50 million people, and we cut short the duration? So that's one question. Second question is, are we making some policy changes based on what we learned in COVID at the federal level? I mean, I feel that we are, but I just want to hear from you.
Yeah. So the first question, did we do something right? Even though I juxtapose them, I think it's hard to make a comparison because of everything was so different in 1918, and there was no influenza vaccine. And I think one of the things that we did remarkably well for COVID was the speed with which we went to the development of a vaccine. I mean, I don't think that's been done before. So yes, it wasn't all doom and gloom. Well, it was a lot of doom and gloom, but there were a lot of good things. I think that a consequence of the COVID-19 pandemic has been that there is a lot more conversation around health disparities and health inequities. I think a consequence of it at the federal level is that there's more funding. I think that it's a window of opportunity. Will the same, if we don't get another pandemic or another, public health crisis in the next 10 years, do I think that 10 years from now there'll be the same amount of funding and the same attention? No, they'll have got distracted by something else, right? So I think that's why I'm like, opportunity, right? Now we have all this funding coming in, we have all this attention, people are listening when they hear us say health inequities and health disparities. And so I think it's a time in history where we have a perhaps unique opportunity to push forward really fast and far.
Wonderful. Thank you very much, Dr. Allison.